We're going to start off with a talk by Jim Robinson on disability management for treating clinicians. So take it away, Jim.
Okay, thank you. Thank you, Mark. And I have given something like this before. I think the slides you have a different font, and I've actually made a few changes. But I think you'll be able to follow along pretty well. Okay, so what I want to talk about is basically a few issues. One, why do disability management in the first place? Second, interactions with patients regarding disability issues. Third, interactions with the disability system. And what I'm thinking about, just so you know, kind of have a picture in mind, I'm thinking about what happens if you're in your practice and you have a 40-year-old person who complains of low back pain that occurred at work. He has a workers' compensation system and is off work and receiving time loss benefits. I'm just thinking, think of this as a kind of modal patient that I have in mind as we're going through this. Now, I would say there are lots of reasons to be a little, what's the right term, ambivalent at best when somebody hands you a disability form to fill out, because it is hard. I have, interestingly enough, gotten away from doing disability management now, and I just got pulled into a case recently, and I'm just suffering the consequences. But one of the things is that when you are involved in, let's say, a workers' compensation claim, it is extremely time-consuming. You have to be looking at a whole bunch of variables above and beyond what you would normally do in terms of evaluating the medical problems that a person has. And there's a substantial risk of conflict, because you may perhaps feel that a worker with a back problem probably could go back to work, but the patient insists that they can't, and it can create a very difficult thing. Are you on their side or are you on the system side? And then, of course, the interactions with the workers' compensation system are dicey. There's always this ethical issue. Whose agent are you? And this, Mark Sullivan and John Lozier, by the way, something very nice on this. It's an ongoing challenge of how much you ally with a patient versus the system. A lot of primary care providers, or for that matter specialists, don't really know a lot about the workers' compensation system, the rules and procedures. So you're dealing with something that you don't know about, and therefore that's a source of discomfort. There is the possibility of conflict and intimidation by the workers' compensation system. Often, for example, independent medical examinations are done, and the doctors, let's say in a panel, will say, you know, the treating physician is entirely wrong. This person has reached maximal benefit. The benefit should be terminated. What's wrong with this treating doctor? And again, it's very time-consuming to deal with the workers' comp system. So the reason to do, two reasons to do disability management, or at least make sure it's done, is that maybe I say you have no choice. Somebody has to do this. You as one provider may have a choice to pass it off to another provider, but somebody has to fill out papers or the patient really suffers. Secondly, another reason in favor of doing disability management is that I believe that return to work is an appropriate goal, and that as we try to treat injured workers, we have to have in mind what it is that they can do as far as return to work. If we don't keep that in mind, we can really miss what's going on with this person, and the patient may be doing, you know, very poorly, and we don't understand it because we're not looking at this dimension of their problem, which is their status in the workplace. So, interactions with patients. It does make sense whenever a person comes in with a back injury to at least find out what is their disability status. And at one extreme, you have people who are already on disability, maybe on Social Security or SSI, where they're basically long-term disability. At the opposite extreme, you may have somebody who's basically, and often this is the case for professionals, attorneys, physicians, teachers, where their back injury is really not a challenge or threat to their job at all. They're worried because they can't play tennis on the weekends, which is important, but it's different from work disability. So you need to find out about what their work status is, and we'll get back to this, patient's perception regarding ability to work. This is a key thing. So it is important to know, when you're doing disability assessment, know the baseline. Most people continue working despite work injuries. 80% of L&I claims do not involve time loss. Time loss starts after 3 days of missed work. So a person may miss a day of work following a cut to the arm or a mild burn, and they're back at work, never file for time loss benefits. 80% go that way. If you look at those who do go on disability, that is start time loss, these are data now from, the publication was 1994, so it's old data, but I think this is a good picture of what typically happens. This is a cohort of L&I claimants, and basically over on the left, where you notice 100%, and everybody starts there because the cohort is defined by the fact that they filed for time loss payments, so they went on disability. So at time zero, everybody is on disability. And what you have here is a set of survival curves showing what is the probability, given that they were on disability at time zero, what's the probability that they will be on time loss or on disability at 1 month, 2 months, and so on. So what you see is a very rapid drop, meaning that more than 50% of the people go off disability within 1 month of going on. But then you see the curve beginning to level out. And if you look, say, at 3 months, you're noticing now beyond that the curve is kind of flat. So if you're on disability 3 months after going on disability, your likelihood of being on disability at the end of 12 months is about 50%. So again, most people go off disability, but the curve flattens out. This curve, interestingly enough, is for different work conditions, if you can see the small print. Interestingly enough, the one with the worst prognosis is carpal tunnel syndrome for whatever reason. I can't tell you that, but you notice that these curves are all very similar in shape. So what are the things that moderate the curve? In other words, given this broad trend of most people not going on disability, of those who go on disability, most of them going off disability within a month. But what are the factors that moderate that? And a very nice study I want to call your attention to, done by people here, Judy Turner, who was on our faculty, Gary Franklin, who's the medical director of Labor and Industries, but looking at injured workers in Washington State, they did interviews with 1,885 workers within about 3 weeks of the time that the workers had a low back injury and filed for disability. And they were able to look at, as their outcome criterion, the time loss status of this individual, or these individuals, at 1 year. And basically the question is, what influenced the likelihood that a person would remain disabled at 1 year? And what they found, the factors that predicted a poor outcome: history of prior workers' compensation injury, injury severity, and they didn't have good markers of this, but if the person had a radiculopathy, they had a worse prognosis than if they had axial low back pain. They didn't have really detailed medical information, but at least that gross thing. Number of pain sites. So if a person says they hurt all over, watch out. I think we've had this kind of conversation at these previous TelePain conferences. Rowland-Morris score. Now, Rowland-Morris score is like the Oswestry Disability Index. It's a self-report thing of how functionally impaired the person perceives himself as being. High score in the Rowland-Morris meant that they had a lower chance of recovery. And by the way, I should have put that in bold because that was the strongest predictor. And we'll get back to that. But Rowland-Morris score was the strongest predictor of good versus bad outcome. Interestingly enough, and we all should hold our heads here unless we have chiropractors in the group, going to a chiropractor as a first practitioner was associated with a better recovery. Going to anybody else was not so good. So we should all be telling our people, if you get hurt, go to a chiropractor. Do not go to a physician. But I thought it was very interesting. And then there were a number of job factors. The people in construction and manufacturing had a worse outcome. People who described their work environment as hectic had a worse outcome. People where there was no light duty offered by the employer had a worse outcome. What was interesting is things that were not found to be predictive. Socioeconomic status was not related to outcome. Legal and administrative things like getting an attorney, not related to outcome. Various personal health behaviors, smoking, BMI, not related to outcome. Also, interestingly enough, the psych factors, catastrophizing and so on, were not related. recovery expectations, I forgot that that was in there, and that in this data set was not related. I'll show you data showing that it is related. But the thing about the catastrophizing and the SF-36 is that they were highly correlated with the Rowland-Morris. So I think that when people say, I can't sit, I can't stand, you are incorporating a lot of their emotional distress in those self-reported functional status things. If we look at other data from many other studies, age is a factor in predicting outcome. Older people do not recover as well. Job variables, as Judy Turner and others found, are important. As far as psychosocial issues, patient prediction is very important. It's been shown in study after study. Interestingly enough, a lot of people cite the Boeing data study that done in the 1980s and 1990s of job satisfaction being predictive. It is not on a consistent basis. This is about patient prediction. This is, and I'll quote, the search identified 24 studies meeting the inclusion criteria. From these studies, there is strong evidence that recovery expectation is predictive of work outcome. So I don't know why the L&I study didn't find this, but this has been found in a number of studies. It is a strong predictor. And so my feeling is, for the bottom line, if you're out there on the front lines, I think about three things. One, if the patient says, there's no way I will ever return to my job, watch out. That is bad. Two, subjective severity of the condition. Pain intensity, Rowland-Morris score, Oswestry disability. If they say, I'm lying in bed 23 hours a day because my pain is so bad, watch out. That's a bad predictor. And then several job factors, like, for example, is there light duty? Okay. I think that beyond the issue of assessment, what if you are managing disability, what can you say? I think that there is evidence that proactive communication to patients who are injured workers helps. If you say, look, Mr. Jones, I think there's room for optimism here. I think you will be able to go back to work and so on. That is helpful. It's also very important to realize if a person says, but my back still hurts, I can't go back to work, very important that you as a clinician understand most people with back injuries return to work before their symptoms are fully resolved. That's a very important point. It is not the case. The person has to be able to play football in order to do a desk job. So another message is that exercise helps physical therapy, and that there is a really good evidence that there is no serious risk of re-injury or worsening of condition for people who participate in physical therapy. That's been looked at carefully, and that's, I think, a statement you can make to your patients. You certainly need to deal with their fear, and because I do think that that is an important factor. If people feel, my gosh, if I do anything, my back will break, it will be important for you as a clinician to be able to help them work through this. It's very important, if you're managing a disability, that you continue to ask about it. There was one clinician in our community who suggested that we should have the SOAP format, subjective, objective, exam or assessment. Let's see, assessment and plan, and then he added it, and then put an R at the end of that. And the fifth thing to consider is return to work. In other words, the point is that should be, if you're working with a disabled worker, you need to be asking about return to work and thinking about return to work in your treatment plan at every visit. You have to watch the clock. People slide downhill. Sitting still in the disability system is iatrogenic. It makes them worse. So you have to be worried about moving forward quickly and not letting time slide by. It's important that you communicate with others. If you're the attending physician for an injured worker, you have to be thinking about the physical therapist, the psychologist, the vocational rehab counselor, the employer, the claims examiner, I didn't put that one in, and the attorney. These people are all part of the system that surrounds the patient. You need to get help. I would say don't let time just drift by with when a person has a back problem. Have them see a spine specialist. Have them see a psychologist. And there is something called the Centers for Occupational Health and Education, which I'll get back to. Okay. All right. So now we're done talking with patients. What do you do interacting with the workers' comp system? And I would say workers' comp is difficult. It's bureaucratic, legalistic. Often the questions that are and demands of the workers' comp system don't make sense from a clinical standpoint. So you're always in a kind of awkward role of trying to match the demands, rules, expectations of the workers' comp system with the clinical realities of your patients. I would say that there is what I'll call the administrative model of injury. It is a very convenient model, unfortunately grossly oversimplified. And there are many key issues, and I don't have time to go into the entire thing, but a key premise of the administrative model of work injury is that incapacitation is, or at least should be, transparent, meaning that somebody else should be able to see what is wrong with a person, so that objective findings correlate with symptoms, and so that an observer can verify the patient's complaints. Let's consider a traumatic amputation. A person gets their hand caught in a machine and it is amputated. That is a visible injury, visible consequences. Compare that with low back pain. Low back pain is an invisible condition. And that is, it's very hard to verify by anybody else why the person says, I cannot sit for more than 10 minutes. And the workers' comp system says basically all conditions should be transparent so that we should be able to see objective measures that correlate highly with the symptoms. The fact, and so this happens all the time. You get messages from your workers' comp people say, doctor, what are the objective findings supporting your conclusion that your patient is unable to work? This happens all the time. This is routine. The question is, how do you do that? Well, let me give you a very nice quote. I think this is from 1986. It was a study of the Social Security system, but Social Security operates by similar rules to workers' comp. And I just like this idea because it frames the dilemma so nicely. So, quote, the notion that all impairments should be verifiable by objective evidence, that is, they should be transparent, is administratively necessary for an entitlement program. Yet this notion is fundamentally at odds with a realistic understanding of how disease and injury operate to incapacitate people. Except for a very few conditions such as the loss of a limb, blindness, deafness, paralysis, or coma, most diseases and injuries do not prevent people from working by mechanical failure. Rather, people are incapacitated by a variety of unbearable sensations when they try to work. So to me, this beautifully encapsulates the dilemma. And you as a clinician are going to be stuck right in the middle of that dilemma because the patient will say, I hurt too much, and the workers' comp system will say, what is the objective evidence? And so, again, this is just restating what I said. The patient reports overwhelming incapacitation from pain, and you cannot find objective evidence that makes that report inevitable. Now, I left out a slide here that's in your slides, and that is looking at the frequency with which this kind of dilemma occurs. And I'll tell you that with even a cursory view of large-scale work disability data, I would say that about 50% of work injuries leading to time loss are defined primarily by the subjective complaints of pain rather than something that physicians can unequivocally evaluate. So this type of dilemma occurs all the time. I did want to mention, just in terms of your interactions with the workers' comp system, that there is help along the way, and the Department of Labor and Industries has been working proactively on what are called Centers for Occupational Health and Education. The Washington State, and I must say I've not looked at this in the last year or two, but the state of Washington mandate that this be available to all injured workers, and the startup time was supposed to be 2014. I honestly don't know whether it actually achieved that goal, but the basic issue is that the COHEs can help manage injured workers, and basically they recommend that physicians who do workers' comp work join a COHE, and if not, that they're willing to basically take over and manage these work compensation claims. There is evidence that the COHEs, that patients who are enrolled in a COHE do get better results, that is, are less likely to have protracted disability than people who are just handled out in the community in general. So I think the COHEs do have something to add and are a resource and should be a resource available to virtually everybody. It's funny because as I'm getting this talk ready, I've got my one patient whom I've agreed to be attending physician on a temporary basis while his other attending physician or his previous attending physician is moving. And I've gotten stuck and killed with administrative burdens that I can't handle. And so I'm going to look into the fact of getting this person off to a COHE. And I think that is a proactive system that L&I is working with that I think you should all consider if you're having a hard time managing disability in an injured worker. And they do encourage physicians throughout the state to basically become participants in COEs, and there's a method for doing that. So I don't want to get lost in that, but just in summary, I like Winston Churchill's thing, because I don't think there are any easy answers to the issue of managing disability when you're, let's say, a primary care provider and you have a few patients who are on workers' comp. Often the reasons why people are disabled are complex and unclear. I think this has come out again and again in our patients we've discussed here, that pain can be very disabling, and yet we often don't know why exactly for one person. You always are in this difficult position of arbitrating between the needs of the patient and the demands of the workers' compensation system. I do think that you need to think about what to do about disability or injured workers that come into your practice. One option is to learn about disability management and make that a substantial part of your practice. That's reasonable. Another is to work with a system or maybe some other provider who does this kind of work. For example, in group health, they have occupational medicine physicians who do most of the disability work. So if a primary care doctor sees one of his patients who he's had for 10 years, develops a back injury, they say, fine, let's get our occupational health physician to work with you on that problem. So that's an example of steering the person to another provider. But I would say you can't just drop these patients because the workers' comp system forces, I guess I shouldn't say you, it forces somebody to be involved. Some practitioner has to sign papers or the injured worker is really punished. And the stakes are very high. And these people who have been injured and they're off work, they are stressed, their ability to hold their families together, to remain so they're not homeless, they're all at stake. The stakes are very high, and you need to take this problem very seriously because, A, the workers' comp system requires this, and B, your patients have a lot at stake.